Greetings, fellow Homo sapiens, and welcome to the Symbiotic podcast. I'm Cole Hans, and my guests today are going to be talking about a fascinating new project that was seed funded with some money from the Huck Institutes here at Penn State. The title of the project is COVID-19 Health Messaging Efficacy and its Impact on Public Perception, Anxiety, and Behavior. Certainly a hot topic. We're having this conversation on May 20. And with me today to talk about this project, we have Dr. Rob Lennon, Associate Professor from Penn State's College of Medicine, who is the PI for this research, Lauren Van Scoy, a critical care physician from Penn State's Qualitative and Mixed Methods Core, Cletis Earle, Chief Information Officer for Penn State Health, and we have Penn State's partner from the private sector on this effort, Russ Branzell, CEO and President of the College of Healthcare Information Management Executives, or CHIME. Welcome to the podcast, everybody.
Thank you.
Thanks for having us.
It's exciting to hear what you've been doing. I know a couple weeks back, I was able to listen in to an online presentation on where you were then, and it seemed like this thing was moving so fast. I'm eager to find out some updates. But for those who have not heard about this project at all, I just want to launch in with the fact that this is largely about a survey. It's largely about trying to find out how people are learning about COVID-19, where they're getting that information, how that information is affecting them, and hoping to take that information and see if we can do a better job with our messaging moving forward. And I took the survey myself and was surprised at the depth of some of these questions. So I would like to first ask, how many questions are there, and how long does it typically take somebody to complete the survey you put together?
So the number of questions you get will change a little bit based on branching logic. So depending on your answers, you may get follow-on questions. Roughly 65 questions will be asked. And the length of time depends mostly on how much free text you'll enter. So we have a number of quantitative data points. If you just go through that, maybe 15 minutes at the tops. And then if you enter a lot of free text, which really gives depth to our answers, some people spend a half an hour on it because they want to. We have free text responses up to 700 words at a time. The net overall average time for the last 8 weeks has been 24 and a half minutes that people have spent on it, which means about 15 minutes of quantitative study, and they've taken about 10 minutes just to give us the depth of their experiences.
Thank you. And could somebody else talk a little bit about the questions that you ask? What kinds of questions are you asking folks to answer?
Yeah, sure. I can take that. So when we designed this survey, we used what's called a convergent mixed methods design. So we looked at various constructs and we asked questions about those constructs with both quantitative questions and qualitative questions. So in our first construct, we look at knowledge, and we're interested to know what is the knowledge that's out there, knowing that obviously knowledge changes on a day-to-day basis. And so we ask some true-false knowledge questions and how confident you are answering those knowledge questions. We also ask questions about perceptions, about some of the health behaviors and recommendations of the CDC, the WHO, and various places across the world for the social media, the global survey. And we ask those questions both quantitatively, and we also ask them with open-ended questions about, barriers, facilitators to carrying out the recommendations. We also ask about information sources. Where are people getting their information, and to what degree do they trust that information, and giving us information, both quantitative and qualitative around those constructs as well.
Thank you. My understanding is that the first time this was launched, it was more a local. Is that correct, Rob? Was it a smaller, just kind of a pilot that went out the door to start?
A very small pilot of about 1,000 people. And when it showed that the answers were sensical, we did a regional study. It was actually so well replied, it crashed the system in REDCap. We had over 8,000 responses, 5,984 of which were completed. And the answers to that gave us what was very concerning. It showed tremendous discrepancy in knowledge and understanding of COVID by various demographics, and we realized we really needed to understand this on a global scale. Since we didn't have the platform capability, we asked our chief information officer, senior VP of it, Cletis Earle, who said, I know exactly who to help. And it was actually April 2nd. It was less than 14 hours after we reached out to Cletis that Russ Branzell and his team showed up the next morning, and the global survey launched 7 days later. That's how long it took to go from a regional survey to international scope, internationally oriented questions. At that time, 20 languages translated, and not just translated in a Google Translate way, but Russ brought in European medical experts. So the translation was not simply word for word, it was medically nuanced. And that also helped us, using his extensive connection with these international partners. It helped us change the way we asked it so that an international audience would respond well to what we were asking. Many people in the world, they've never heard of CDC, but they've heard of World Health Organization. They've heard of the European Commission. So that was an incredible thing to have. What CHIME brought to the table, and that was just light speed in terms of academic medical terms.
Fantastic. And Russ, did you have a previous Penn State connection, or how did you get roped into this thing?
Well, not necessarily a previous Penn State, but a previous Cletis Earle connection. How about that? Or a current Cletis Earle connection. Cletis has been a longtime member of our organization and actually was our chair several years ago of our board of trustees, and a long time just good friend. He and I have hung around each other for a long time, and he did know one thing from his experience of time on our board. We do have a problem at CHIME of the inability to say no. Even if we definitely don't even necessarily know what we're talking about at the time, we're going to figure it out really fast. In this case, with work with Cletis, he knew this was an area that we probably could bring the right resources to bear with our network. Again, we've built a quite extensive network of really, really highly talented people around the world. Not just technicians, but really leaders in the field of health IT. And it was really a blessing to get a weird phone call from Cletis at 9-something in the evening on that Thursday night saying, hey, got an idea. What do you think?
Got it. And when Cletis came to you with that, the pilot had already been done, correct? And it had crashed the server, I think Rob said a minute ago. And then, so what were you able to do taking the initial data that they had pulled in from the pilot? How did you manage to just deploy that so quickly to the globe?
Yeah, so it was actually a lot of fun because I didn't actually call the rest of our team that night. I actually stewed on a little bit, and I kind of called a quick meeting in the morning, which we do anyway in response to all the COVID issues going on. We just started a little bit early, and I said, hey, you're not going to believe who I heard from last night. It was Cletis, our old friend and chair. He has this idea, and I laid out the idea, and I let him and haw for about 5 or 10 minutes. And I said, oh, by the way, you can him and haw all you want. I already said, yes, we're going to do it. And then we knew how. And then there was a very long period of silence. And he said, okay, so, all right, boss, you do this to us all the time. Now what the heck are you going to do with it? And I said, actually, I've already made a few phone calls. And we've got a great tech partner who supports us with all of our efforts to be able to be global. Does a lot of behind the scenes technical work, a lot of work with Amazon and Google and Microsoft in this case particular. And we gave them a quick call and said, we don't have a lot of money. We don't have a whole lot of technical expertise. We know exactly what we want to do, except we're not sure quite how to do it. You want to help us? And they said, sure, we'll jump on board. And I think our first meeting literally was that afternoon. And then I think we actually had most of the shell and technology built for this on a scaled basis, not translated, by that Sunday afternoon.
Yeah.
I'll even say for me, this was a little fast for normal technology. I like going really fast and really bold. But I think even when I called Cletis that Sunday morning and said, hey, Cletis, you're not going to believe this, but they think they're done with the first phase of this. Even I think he was shocked and I was shocked. By the time we got together on Monday morning, I think the basic tech platform was built, and good Dr. Lennon there. I think you were even a little bit surprised, but I think it gave us the catalyst to move really fast for the right reasons to try to make an impact on this.
Terrific. And how many sort of nodes in the network are there globally in total that are participating now with this survey?
Dr. Lennon, I don't know how many different countries and places are working on this at this point. I know there's a lot, something in the neighborhood of post 70, but I do know the ability to connect globally on this platform now is limitless. We can connect anywhere, anytime with, I think the number is 98% of the languages of the world represented. at this point. And Dr. Lennon, you may want to give more specificity. I will just say I've never heard of anything like this anywhere to be able to scale out of one point. But again, a lot of it has to do with cloud technology now. You don't have to host things anymore. You use a scaled global platform.
Well, Rob, do you have current numbers on like number of nations, and how are you tracking that? How are you keeping track?
We do. So, well, we do it by asking. So we ask people if they're from the United States, and if they are, we get the first 3 digits of their zip code. We've had every 3-digit prefix in the United States. So we have representatives from all 50 states, the District of Columbia and so forth. And then if they're not from the United States, we ask what country they're from, and they tell us. We have over 73 countries. Every continent is represented. And it's all by snowball effect. So there are people in different countries that see this and push this out, and that's a key element of this. People like Bob Mash, who's at Stellenbosch University in South Africa. He runs something called PrimaFed, which is a primary care network in Africa. He's very interested in this because this really helps them get at how to take care of folks. And that's how it's spreading though. So 73 countries to date, over 3 countries with over 100 respondents, which is enough to show significant differences in outcomes, and several more approaching that as we go forward.
Cool. I'm Cole Hans. This is the Symbiotic Podcast. We're going to take just a quick little break, and then we're going to get back into a deeper conversation about what kinds of things you're learning from all these people from around the world, and what you plan to do with the data now that you're collecting it. Thanks a lot. We'll be back in just a moment. Don't go anywhere. The Huck Institutes of the Life Sciences at Penn State offers 6 inter-college graduate degree programs in bioinformatics and genomics, ecology, integrative and biomedical physiology, molecular, cellular, and integrative biosciences, neuroscience, and plant biology. We also offer an accelerated professional science master's program in biotechnology. At the Huck, we immerse students in a groundbreaking environment built on interdisciplinary collaboration among some of the world's most innovative research scientists, and our students receive unparalleled access to bleeding-edge technology in world-class core facilities. If you're looking for a deeper, more holistic grad school experience, you owe it to yourself to look at the Huck. Visit us online today at huck.psu.edu. Welcome back to the Symbiotic Podcast. I'm Cole Hans here with my colleagues from Penn State and a partner from CHIME, talking about a global survey that's digging deep into what people think and feel about COVID-19, what they know about it and don't know. And I just want to share that when I took this survey myself, I was really surprised at the depth of the questions, and I found myself really doing a lot of deep self-reflection, and I kind of got to understand my own feelings and thoughts about COVID in a way that I wouldn't have if I hadn't done the survey. I found that very surprising, and I wonder if that was intentional. Rob, I don't know specifically what your purpose was in this, but was that all by design to have people do a deeper dive, and what kind of responses are you getting by taking that approach?
It was by design. I have taught at universities for many years, and I feel that the best exams teach you things. When you get done taking a really good exam, it's not that it's examined your knowledge, it's that you've learned something from how questions can be asked. And that was the point of going into depth. And we got a lot of pushback from that. People that do surveys know that the longer the survey is, the less response you're going to get. And we got a lot of pushback on going into the depth. And my response to that was, we have to know. We have to know to this depth. We have to understand this. And we're so early in the pandemic, we're not even sure what questions to ask. So we have to have open-ended questions, and we have to ask a lot of them. And I was confident that people would talk about it. This will be the defining event of a generation. Certainly people can take a few minutes to talk about their experience and how it relates.
When I first met Rob and we were sitting around Dr. Ruffin's conference table before social distancing came, and we were designing this survey, I was skeptical that we would get good qualitative responses from a survey. Because in general, when you ask qualitative on a survey and you ask people to free text, whether, their opinions or their feelings about something, they'll give you very superficial answers, just sort of get her done. What do you think about this? I think it's great, period, the end. And sometimes people just will write no comment, or they'll leave it blank. And so I was sort of skeptical that we would get good qualitative data. But what we learned pretty immediately, actually, when we were doing the cognitive interviews for the survey to sort of validate the survey or do what we could to validate it, is that people were wanting to talk about COVID, particularly in March, April, when we were making the survey, because it was happening. It was hot. It was on everybody's mind. There was a lot of chaos and change, and people were anxious. And one of the questions in our survey is, what worries you the most about COVID-19? And oh my goodness, the data that we got from that just on the cognitive phone interviews was just out of this world rich. And as a qualitative researcher, I was so excited because I thought, if we can get this stuff written down in the survey form and people can actually share with us, then we're going to have these really rich stories and be able to understand things that others doing survey research may not be able to understand. And I think COVID-19 is unique in that way, because people want to talk about it, and they do spend the extra 10 minutes to provide us with good qualitative data. And that's something that's been really, really flabbergasting to me.
It'd be interesting to see if there's any correlation to the shift of how people respond because of COVID overload, and seeing if there's a dynamic of diversity in that manner. So it'd be interesting to look at it. And that's what makes this so fun and so interesting, that we'll have enough data to kind of look at this, holistically and come back with some conclusions.
We almost joked about it when we first started this. The very first time I took the survey, I think it was still a little bit in draft form, and a few of us got together, and I said, okay, I've been reading everything from the CDC. I've been getting all this stuff from my local doctors and health systems, and I'm an expert on this. And I immediately came away and said, I'm not sure I know anything at this point. I realized how much I didn't know, or there was a lot of misinformation out there. And I think as this survey has truly rolled out on a global scale, what we're seeing is a common response. And I'm talking about people that run health systems. I'm talking about people that are in technical positions in corporations that are very involved with this from a frontline perspective. And their feedback almost always, to a person, I mean, without exception, not one exception. I've talked to probably 100 people that have taken the survey, though. Every one of them has said the same thing. I thought I knew stuff that I obviously didn't know, including me, by the way.
And you see, we're still combating, this misinformation or a lack thereof of getting information from certain sectors and certain populations. We see there's a huge disconnect between the minority communities, people of color, and the impact there. So there's some components that we really want to continue to push out this survey and continue to hit the ground and trying to get as many people to participate, because there's a disconnect that's going on. And again, the whole goal is, to remove the misinformation that's out there and try to get use our survey results to really make a difference.
Well, what's really amazing is our organization gets to talk almost every day to people around the globe, at least if not around the United States. In any given day, just talking to our own team in CHIME, we've got one group in Ann Arbor, Michigan, which is in complete lockdown still. They're not even allowed to take most things like graduations. And then I live in Georgia, which is the home of the wild and the free, and everybody's doing anything they want at this point, it seems like. And it's just amazing the perspective that individuals have based on the environment in which they live and have to operate. And we even spend time within our team debunking some of this misinformation between the two, because the normal and usually correct answer is probably somewhere in the middle between these extreme perspectives being taken around the country and around the globe.
Yeah, when you take it to the international community, then are you getting any early indicators? I mean, when you have a survey that's so in depth with so many words, it's not like processing. Maybe LJ could speak to that a little bit, because it's all this stuff to take in. How do you even condense that down and say, oh, the United States versus Norway versus Brazil or whatever it is? How are you going to manage that? And have you been able to see any trends start to emerge yet?
Well, it's going to be really difficult to manage. I will say, as a traditional qualitative researcher, this is probably the largest sample size I will ever encounter. Oftentimes we do qualitative research with 20 people's responses. 100 people's responses. 200 may seem large. We have already 8,000, and we've really just started. In our local survey, I say local, we had 6,000 responses. We're just very slowly starting to, read the data and find the themes, doing traditional qualitative analyses, but it's abundantly clear that that's not going to be sufficient for such a large database. I only speak one language, so we have to get linguists to translate all of our qualitative responses. And we're interested in natural language processing and other tools that we can use to try to help us organize the data. Not such that the machinery or the AI would analyze the data for us, but help us to organize it in a way so that we can start to make sense of it and know what better questions to ask of our data set. So I think that this process is going to be a long one of reading, rereading, organizing, reorganizing, asking the data set different questions, both qualitatively and quantitatively, and what they call following the thread, taking the research where the data leads us.
Thank you. And then, what does the timeline look like? The current version of the survey, how long is that going to be live, and what are next steps?
It will be live at least through June 30th. We have grants pending at the National Science Foundation, Facebook, and soon to be at the Russell Sage Foundation to help continue this going on. As the COVID experience continues, it makes a lot more sense to keep it open. And as Cletis has mentioned before, looking at changes in response over time is also likely going to be very valuable. We can pinpoint specific things in time that happened and compare responses afterwards. We haven't been able to do, as LJ mentioned, we can't do the linguistic comparisons yet, but by building the data set, cultural anthropologists will be able to do this. And if the data set becomes robust enough, it literally will be a process of years to do that. Numerically, we're waiting until we get responses in the hundreds to do international comparisons. But just recently, we did preliminary analysis on quantitative answers, and that was actually prompted by Russ, who said, "What have you found?" And we said, "Well, we thought we'd wait a little longer." And he said, "Well, stop waiting. Tell me what you see." And I said, "Okay." And
time speed.
And I'm actually very grateful that he prompted us to do that, because we found some very disturbing things. We found that there were statistically significant and almost certainly clinically significant differences in the public's intent to comply with CDC recommendations. And the reason that's so important is as you lift the lockdowns, the resurgence rate, we think, will correlate to intent to comply with them. So people, the best predictor of human behavior is what did they do before? Well, no one's ever come out of lockdown before, so we don't know. The next best thing is to ask them what they're going to do. Well, we did, and we found that in a lot of places, they're not going to comply with CDC recommendations. That's very, very concerning. And in fact, the paper on that, we completed it rapidly because we were so concerned with the data. It's submitted, it's not peer review yet, it's still under submission, but we'll be releasing it because it's, in our opinion, an imminent public health threat. So we're already receiving this kind of data, which might have pretty profound implications on it. That doesn't mean reopening is good or bad. The data is what it is. The data suggests that if people don't get better education and comply with these, they're at much higher risk. So the natural response is, if you're going to let people make these choices, for goodness sake, get them the information they need to make better choices and keep themselves and their communities safe.
If I could just add to that, one of the things that we're going to learn in the qualitative data is sort of why we're seeing, the lack of intent to comply with the CDC recommendations. So the quantitative will answer the question of what are they intending to do? What percentage of people are planning to comply with the recommendations. But for those that aren't going to do so, or those that are going to do so, we want to better understand why or why not. And that's why the qualitative questions will be so important, because we're going to understand the reasons, the thought processes, hopefully, behind some of the data. So in a sense, we're going to be able to explain some of our quantitative data through looking at the way people respond to the qualitative answers as well.
Got it. And then what's the end game here? Is it publish a paper and then maybe a white paper that goes to policymakers to influence things in the future? Is that the vision here?
The first goal, what we set out to have, is to produce actionable data that can impact human health today. And that's what we're doing by releasing this information now, to say there's people out there. We have we have the analysis to show that they're at risk, and we can change that now. So getting that out, that's the real goal. And if we ended with that, that's a noble thing to do. The papers that will come out of this will be a great number of them. Some of the most interesting papers are actually simply on informatics. So the professionals that study news consumption in America were very excited when they heard about our survey. They commented that the last time Americans changed their news consumption was after 9/11. They were convinced that COVID would change it, but nobody had any idea how. So they don't know where people are going. And I told them, I was like, well, we're about to ask every online person in the world, what do you want to ask? And they helped us craft the questions to get meaningful data out of that. So it's not just that we'll get medical information, we will get information. Just to the news media alone, we'll find that interesting and how health information is shared. The data that we're going to get on how we built this partnership will also change things. A mixed methods study typically takes 3 to 5 years to go from concept to completion in a validated survey. We did that in about 3.5 weeks, and we are already getting actionable data. We did that by an academic private foundation partnership. That has extraordinary implications for how quickly research can move. Now, that doesn't mean it's not without its flaws. Anytime you move quickly like that, there are limitations to your data, to how it's collected, freely admitted, and we are the first to pick our methods apart. But it shows what you can do, so that when we're faced with these catastrophic events, we have shown that you can do this. You can go from zero to robust analysis much quicker than we typically do. It's not just good for COVID, but imagine earthquakes, hurricanes, other natural disasters. These are all things where, by working in partnership and cross-disciplinary teams, we can move very quickly and get very actionable data.
If I could add, you asked about the end game, and I think this is interesting that this has turned to the now game as well. And I'll again continue to talk about the disparities between how we're seeing it being impacted, people of color being impacted. What happened while we were seeing this and seeing that whether the type of responses we were getting or not getting, we actually ended up pivoting, and we're doing kind of parallel strategies to deal with the now. To try to figure out how do we now get information to and from certain communities, and we're tackling that now. It's become an organic piece. I'm so glad that Dr. Lennon reached out to us and asked for that kind of partnership, because now we're really seeing that we are in our side of the shop. We're in the business of making people better, right, and trying to improve healthcare for our patients and our communities. This is allowing us to adjust in almost a real-time basis and being able to try to do something about it, working with CHIME to figure out what can we do from a legislative side. How can we go to DC? What can we do to actually be change agents of this change and start to lobby in different ways to say, how do we make a change for what we're seeing almost near time? I don't think it's been done before at this level of engagement with this public-private conversation. This is amazing.
Yeah, and if I could, I'll just throw this out there. And how do you get a whole bunch of people to do things over a weekend when they're already working 40, 50, 60 hours a week? You give them a compelling vision. And it was this simple at the beginning. And I will say between Cletis and Dr. Lennon, it was pretty easy to make this pitch. And that was, there's really two goals that I try to push out there. One, we're going to save lives right out of the get-go. I don't know if we can directly prove this, but I have direct confidence in this. If we can help improve the education, make people aware of this, there are going to be people alive. They may not know why, but they will be alive years from now because of stuff that happens today. And I know we can prove that in many other places within health IT. I think the other is we need to be ready for the next time. Even though we're right in the middle of this, it does not take you much long in history, and history is years. You've got MERS, you've got SARS, you've got Zika, you've got West Nile. You can just, the number is multiple hands. These were all within the last 5 to 10 years. So yes, COVID-19 is here. It is horrible. We want to get rid of it. But whatever is going to be the name after this, it will come. There is no doubt. That is just the way virology works in the world. The next thing will mutate and it will come. We need to be ready for it. And so there is a process that we need to put in place differently than we have today. And I believe the work that Penn State's doing, and specifically credit to Dr. Lennon for these ideas, will shape the way we respond in the future. Hopefully proactively enough that we don't even have the problem to begin with.
Fantastic. Well, thank you all for those inspiring comments. Yeah, I can see this is a very purpose-driven project. You can feel it. It's inspiring. I wish you all the luck in the world. I do want to share with all of our viewers and listeners, we're going to put a link so that people can take this survey while it is up. So what is the best way that people can get online and just sit down for a little bit and have some reflective time and go deep and participate with this survey while it's running?
It's easy. We're asking people to go to covidsurvey.psu.edu and you get right to the link.
I did it. I recommend it. I think everybody should participate because it's for us right now, as you're saying, like actionable data that people can respond to now. You're moving quickly with this, but also into the future, as Russ was just talking about. So we can get better at this, so we can be better informed, better prepared for future similar challenges and help to transform the industry. I salute you all. You're doing what we believe in here at the Symbiotic podcast. You're cutting across those disciplinary boundaries, bringing together medicine and IT and research and communication to do something meaningful that helps to evolve the way science is done. So thanks for what you're doing. Thanks again for being on the podcast. I wish you all the best. Take good care
Thank you, everybody.
in this pandemic. Stay healthy. Thanks a lot.
Thank you.
Thank you, everyone.